Okay. Well, thank you so much for inviting me this afternoon to talk to your members of your Perinatal Quality Collaborative. This is one of the things that for us has been so valuable in participating in AIM is working with other states and just the collaboration and all of the relationships.
Melanie Blake and Deborah Alanis from DeKalb Medical.
And networks that have developed over these years that we participated. So thank you so much, Grace, for inviting me. And I'm going to share a little bit about some background just to give you some context. The Oklahoma Perinatal Quality Improvement Collaborative, our vision is creating a culture of excellence in perinatal care. So in Oklahoma, we currently have 50 birthing hospitals. 58% of those are located in a rural location and 42% in an urban location. And then when you look at are you seeing mine?
Oh, it just went out. Hold on one second.
Okay, let's see.
Let me fix it. Yeah, it's coming back.
You got it now? Okay, sorry about that. When you look at where the births are occurring, they are, it's pretty much flipped. We have 52,000 annual births in Oklahoma. 69% of those occur in an urban hospital and 31% in a rural hospital. And the annual births range of our birthing hospitals is from approximately 80 annual births to 4,700. 60% of our births in Oklahoma are covered by Medicaid. We had 48 of these 50 hospitals signed on to participate in AIM, and our kickoff was a couple years ago, or 3 years ago in 2015. 42 out of those 50 hospitals are actively participating, affecting 90% of our births. And we are working on both the hemorrhage and the severe hypertension bundle. So this is where when you look at Oklahoma, we have 77 counties, and 28 of those counties have a birthing hospital, and you can see most of those are located in the central portion of the state where Oklahoma City is located, and in Tulsa in the northeast. Back now 4 years ago, the National Partnership for Maternal Safety released their current commentary about maternal mortality in the United States, and their recommendation was that every U.S. birthing facility should have these 3 bundles, and they should be in place 3 bundles in 3 years. So we took that pretty seriously and started thinking about how are we going to work on these bundles. These were the hemorrhage bundles, the hypertension, and the maternal venous thromboembolism prevention bundle. In Oklahoma, we had previously had a statewide collaborative effort called Every Week Counts to reduce early elective deliveries that ended in 2014. So we launched Every Mother Counts in 2015 in response to this National Partnership for Maternal Safety call to action, and our Oklahoma Maternal Mortality Review and CDC data. Hospitals were recruited via email and telephone, and we had our kickoff meeting in April of 2015. At that same time, the Alliance for Innovation in Maternal Health was getting started. So I knew that this was going on and lobbied pretty hard for us to be the first state. I knew the resources and the data portal especially would assist in our bundle implementation. And we did decide to work on both hemorrhage and hypertension. Some hospitals, they could choose one or the other. Most are working on both. Some hospitals decided to do one and then the other. So a lot of our hospitals had participated in a management program we had had previously on OB hemorrhage, so they wanted to go ahead and get started with the hypertension bundle. So that was 3 years ago, and looking at the AIM framework, that really helps us with our bundle implementation. We have the hospital level and state level and national level, and you guys then will be able to experience that working together as a state, and then all of the national resources that are available to you as well. As we started entering data into the data portal, that began in for quarter 4 of 2015. We could start entering data for that quarter on January 1st of 2016. So that's pretty much when the AIM data portal became open for entry. In Oklahoma, the way we're doing it is the State Department of Health submits our outcome measures. Our hospital discharge data are submitted directly from our State Department of Health to the AIM data portal, and then the hospitals individually enter their structure and process measures. So as we got some data that entered into the data portal, we could see what our priorities were. And I'm going to just talk about hemorrhage today, since that's what you guys are going to be working on in Georgia. Our priorities through our data informed us that we needed to work on the hemorrhage cart, management plan for obstetric hemorrhage, risk assessment for obstetric hemorrhage, and the quantification of blood loss. So let me show you successes with our data, and then I'm going to talk to you about some challenges and how we've overcome those challenges, and give you some lessons that we've learned along the way. Looking at our hemorrhage cart data, you can see that 40 months prior to the kickoff, we had 12.5% of our hospitals had a hemorrhage cart, and now we have 95.8% of our hospitals have a hemorrhage cart in place. So this is something I'll talk about later. This is an easy win. It's a good place to start. If you don't have a hemorrhage cart, it's probably the easiest thing to do, and we've seen then 666% increase since the January of 2012 in hospitals that have this structure in place. Then looking at our hemorrhage unit policy and procedure, this was another priority. If you don't have a policy and procedure, it's kind of hard to do the other things. So this really needs to be started on first to guide your work. And when we started, if you go back to January 2012, we had 4.2 of our hospitals that had a unit policy and procedure in place that was a stage-based management protocol for hemorrhage, and now we have 83.3% of our hospitals have this in place. So this has been a large increase since a few years ago of hospitals that have this policy and procedure in place. Risk assessment, I mentioned, was another priority, and for the hemorrhage risk assessment, and the way AIM defines this is that a woman has her risk assessed and it's communicated to the team at least once during the interpartum period. So when we began, this is a process measure that the hospitals enter, and so it's measured quarterly. Quarter 4 2015 data showed that we had about 62% of our hospitals that were performing this process, and now we have about 88% of our hospitals that are consistently performing this process. So that's a 41% increase. And then looking at quantitative blood loss measurement, this has been the most challenging. It is the most complex process to implement. So you can see when we started that quarter 4 2015, about little over 30% of our hospitals had this in place. And quarter 4 2017, we're up to almost 60% of our hospitals that have this in place. And I'll talk a little bit more about this when we talk about our challenges. So we've seen an 86% increase in this process. And this data is what I find really exciting this is our outcome data that is submitted again by the health department, and all of the data points prior to that are before the black line are before we initiated the AIM collaborative, and the data points after the black line are subsequent to the participation in AIM. So overall, when we look at severe maternal morbidity among all delivering women, we've had a 24% decrease. So in Oklahoma, that translates to approximately 5 less women per week experience severe maternal morbidity. So when you think about the launch of a family that occurs with every birth, that's pretty significant that 5 less women would experience severe maternal morbidity at the time of the birth of their infant. So this also coincided with ACOG's press release where they looked at 4 states. We were one of the 4 states here, and this came out the beginning of this year, and they saw an overall 20% decrease in severe maternal morbidity. So what are our challenges and barriers? We did an informal survey, and this is not anything scientific, just asking the nurses and doctors that are participating what are their challenges and barriers to implementation of the bundles. Out of all of the nurses, 100% of them said their biggest barrier is lack of provider compliance with protocols. And here are some quotations, and I will go over in a little bit how we've addressed these challenges. Physicians are not aware of protocol and bundles. We can't mandate education. They don't buy in. What do we do when a physician states they don't believe our QBL amount and they're going to have a different EBL amount? This creates conflict and a dilemma. We hear a lot of those are just recommendations, not hard, fast rules. There must be a physician champion aware of evidence, supporting change, and willing to speak up and promote change, not often a popular or sought-after role. Looking at some more responses from the nurses, time, especially with multiple priorities. The need for bundles to be physician-driven instead of nursing-driven. Real-life situations don't always fit in a bundle. And staff turnover. So turning now to physician responses, the biggest barrier is lack of awareness of the bundles and protocols. Don't assume they know about the bundles. Time constraints. Needing evidence to support change. And a quote here, in my opinion, we're skeptics by nature. So if someone can't give me a really good reason for why I'm going to change the way I've always done things, it's hard for me to change. So how have we addressed these challenges? And I don't think that we're unique when you look at all of the other states that are participating in AIM. I think most states have experienced similar challenges to those that we've experienced here. With the provider resistance, I think one of the keys is recruiting champions from the very beginning. So now you all are getting started. Talk about this and get those champions on board. Get people involved in all of your different work groups from different types of providers with nurses and OBs and family practice, anesthesia, all of those different types of people, get them on board, starting now at the very beginning so that they're part of the whole process. We've found that using old-fashioned methods for creating awareness works pretty good. Put copies of the bundles in the restrooms, on call rooms, on the units. A lot of busy healthcare providers don't read emails regularly, so putting things where they can't miss it is a good way to start, so that everyone is aware of what's going on and they can't say, well, I didn't read my email. Making sure that you use lots of different ways to create the awareness, and sometimes these old-fashioned ways work pretty well. Holding people accountable. This has been a challenge, and I think for our hospitals at the nursing level, you may not have a lot of control over this, but if the leadership within your perinatal safety committee or within your OB medical staff or your hospital leadership will hold physicians accountable using this as part of their credentialing process can work. And really the best way to, if individuals understand their individual compliance, then they can see the pieces of the puzzle. A lot of times they're not aware, and this can apply to nurses too. So we're working on severe hypertension, so that's one that could be easier to drill down to an individual nurse, that making sure that these kind of benchmarks and the quality data include your different AIM measures, and that they are reported on at your different meetings and on the individual level as well. You do have the opportunity to include this as part of their maintenance of certification for physicians. So if they are participating on your committee for this in a work group, they can use that as their maintenance of certification. So this is a benefit for them. For your nurses, use it as part of a clinical ladder. Delegate all of these responsibilities so you have everyone working on this as a team. And empowering those champions. So I look at this as sometimes you hear a lot of negative talk. So talk to people up front. Hey, we need your help to ensure that the conversations that are out there in the unit are end up in a positive way, and so that things are not people are not talking down on what's happening. And it is hard to change, but as you can see from our data, it is helping families, and we don't have enough maternal deaths in Oklahoma to see whether now we're making a difference yet, but I'm sure that we are saving lives as well. So that makes it worth it. Including your state professional organizations, ACOG and A1, getting them involved, anesthesia, family practice, your DOs, if you have an ACOG chapter there in Georgia, getting those organizations involved to include this on their agenda when they have different meetings can be very helpful. So then they're hearing about it in lots of different ways. The time, that is a factor that is just really hard to address. We're all very busy, but I think the best way is to get, as I said before, lots of people working on this together. The nurse manager and directors may not be the person that's going to have time to enter data, and you may need to do some chart audits. So how can your nurses help, or other team members help you with these different types of tasks? Share the wealth here and get everyone involved. I think then it's hard to talk badly about or sabotage something that you're involved in, so it gets people involved on the team as well to do this good work. The other thing is, know that in the long term this is going to Grace, can you hear me? Knowing that this will improve your performance in the long term, thinking about how did you respond to a postpartum hemorrhage before a stage-based management protocol, and how this can make your response so much more organized, and everyone's working as a team, and you'll feel much better about it, have less, when you debrief, things that are positive instead of things that need improvement. So in the long term, this will definitely improve your performance, and we've heard anecdotes from our hospitals about this as well. Regular QI meetings is very helpful to create deadlines, and one of the tools that we created, and it's on our website, you're free to use it, we have a worksheet for every bundle and all the bundle elements, the readiness, recognition, response, and reporting. So this can be helpful for you to organize your work. So using those and creating those deadlines so that you're having these meetings, right now when you're getting started, you might have them weekly or every other week. It might be too long to wait a month because too much can happen in a month and then you're not keeping up with all of the tasks. So this can be very helpful to create those deadlines that you're continue to work on and address your bundle implementation. Whether these are physician-driven or nursing-driven, again, I think involving all on your improvement team is the way to help this. We found that really it takes both. It's hard to implement if physicians are not on board, but it's also very hard to implement if the nurses are not pushing this. So I would encourage you, again, to get all different types of providers involved in your improvement team. Real-life situations don't fit in a bundle, and this is where your clinical judgment comes in. So, yes, everything is always not black and white, and it can be more gray, but this is why we do what we do, and we do have that clinical judgment to fit these situations. Staff turnover. This is another one that's really hard to address. I think mainly creating a healthy work environment so that staff want to work in your hospital, and one of the ways that you can do this is by implementing these bundles. So I think it helps for all of you all to not only will your outcomes improve, but probably your work experience and whether people like where they work also will definitely improve as well when you're working together as a team. Evidence to support change, and I think in the bundle there's definitely lots of evidence and resources within those bundles that support why you're doing what you're doing. So making sure that you go back to those, and a lot of our hospitals will even make copies of something and put it in a call room for someone to read, things like that, so that those resources are out there. And so a lot of the keys to the success, I think, with just working, as I mentioned at the very beginning, through AIM as a national process is really helpful, and all of the resources and everything that are available that we could not do as a state, and certainly it'd be very challenging for hospitals to do that as a hospital. All of the partnerships that you all probably have already developed and will continue to develop are very helpful, that you can just contact each other and say, hey, how do you do this? Is I think one of the biggest keys to success. The data portal for us, I know you all are going to be using it a little bit differently than we are, but that's something that has been extremely helpful for us and driving that change. And having the national champions and your local champions certainly promote success. And one lesson that we've also learned is that simulation drives improvement and sustainment. So if you're not working on simulations, start doing that now. As you're getting your protocols in place, it's a good way to educate on the protocols, and certainly continuing doing the simulation will drive the improvement and keep things sustained. So some of the lessons that we've learned, as I mentioned at the beginning, hemorrhage card is an easy win, so that's a good first step if you don't already have that in place. Begin early on your stage-based management protocol, because you need that to support your clinical practice and everything else that you're doing. So if you don't have this protocol in place, get a work group together to start working on it, and a lot of that work can be done behind the scenes while you're working on other things. Incorporate these things into your EMR, into your order sets, anything that makes it easier for the flow of the process makes it easier to incorporate. As I mentioned, the quantitative blood loss is the most complex process. You need to purchase equipment so you can start looking at that now. And when you are ready to implement that, what we found is for hospitals to start with a smaller group. So some will start with vaginal deliveries, or start with C-sections, or start with a certain physician's patients, start on day shift or night shift. Not always best to divide things up by day and night shift, but I think starting small and then finding out where your hiccups are and what you need to improve can be very helpful instead of starting with everyone at the very beginning. And using that quality improvement process of Plan, Do, Study, Act, and I know it's some of these things are pretty theoretical, and nurses sometimes are not theoretical. We want to get in there and do it. But all of these tools with the driver diagrams and your Plan, Do, Study, Act process, that's how you can make it work. So don't forget that process. And again, we have some tools I'll show you here on our website that you're free to go to our website and use our tools as well. So be engaged and passionately engaged at the local, state, and national level. I was in a meeting at the beginning of this year, and somebody said, passionate people collapse time frames. And I think this is very true. And so for you as an individual, certainly being a cheerleader for this and promoting this work, it can be very advantageous. And however you can participate in your hospital, at your state level, at your national level. I think there's probably a lot of nurses on this call going to the A1 convention in Tampa at the end of June, and there'll be some different presentations on this subject. So, getting involved, learning what you can, and being engaged, I think, is the most helpful thing that each individual can do. So here is our website. It's OPQIC.org, and I'm not going to go to it here, but if you want to explore, when you look at initiatives here, you can drop down and see AIM, and you'll see a lot of resources there that may be helpful. And there's also, we have it broken down, Every Mother Counts is more of the clinical resources. So if you care to look at what we've done, we're happy to share. And here is my contact information. I'm happy to answer any questions now, or if you want to contact me by email, please feel free to do so. So thank you very much, Grace, and I will turn it over to you.